Welcome. Before this story begins, understand this: what you're about to hear is not a legend, not a rumor, but a case from history that left science without answers. In 1862 Mississippi, a young slave boy survived conditions that should have ended his life, and yet he lived. This video is based on deep research, verified historical records, and true data that took countless hours to uncover and cross-check. So if you value real stories told responsibly, make sure you subscribe. Also, tell me in the comments, where are you watching from? Because this story traveled across time, and now it has reached you. In 1862, Mississippi existed in a medical world that was dangerously underdeveloped and deeply influenced by war, slavery, and widespread poverty. The American Civil War had severely disrupted supply chains, destroyed infrastructure, and overwhelmed the already fragile healthcare system. Hospitals were overcrowded, understaffed, and poorly equipped, while rural areas often had no access to trained physicians at all. Medical care was inconsistent and largely dependent on social status, leaving enslaved people with little to no professional treatment. In this environment, even minor illnesses could quickly become life-threatening. Medical knowledge in 1862 was severely limited by the absence of germ theory. Doctors did not yet understand that bacteria and microorganisms caused infection, so sterilization of instruments, clean surgical environments, and basic hygiene were not standard practices. Disease was commonly blamed on bad air or imbalances within the body rather than identifiable pathogens. As a result, treatments often addressed symptoms incorrectly and sometimes caused more harm than good. Infections spread rapidly in hospitals and homes, making survival from wounds or surgery extremely unlikely. Common medical treatments in Mississippi during this time were harsh and often dangerous. Bloodletting was still widely practiced, despite its tendency to weaken already sick patients. Mercury-based medicines, such as calomel, were frequently prescribed and caused severe poisoning with repeated use. Opium-based drugs like laudanum were used to manage pain, but often led to dependency or overdose. Surgical procedures were performed with minimal anesthesia and without sterile tools, leading to high rates of post-operative infection and death. Mississippi's climate further worsened medical conditions. Hot temperatures, high humidity, and standing water created ideal environments for disease. Malaria, yellow fever, dysentery, typhoid fever, and tuberculosis were common and frequently fatal. Poor sanitation and contaminated drinking water contributed to constant outbreaks. Without antibiotics or effective treatments, the body's immune system was the only defense, and many patients, especially children, did not survive prolonged illness. Nutrition played a critical role in survival, yet malnutrition was widespread, particularly among enslaved populations. Diets were limited and lacked essential nutrients, severely weakening immune systems and slowing healing. Children suffered the most, as chronic undernourishment impaired physical development and resilience. From a medical perspective, a malnourished child enduring serious illness or injury would have been considered medically hopeless under 1862 standards. Racial inequality defined access to medical care in Mississippi. Enslaved people were treated as property rather than patients, and medical attention was often motivated by economic value instead of human concern. Pain relief was minimal, recovery time was rarely allowed, and experimental or neglectful treatment was common. Combined with brutal living conditions and forced labor, the medical reality of 1862 Mississippi made survival from severe trauma or disease, especially for an enslaved child, something science of the time could not explain. In 1862 Mississippi, physical trauma often meant death, especially for children. Medical science had limited understanding of internal injuries, shock, blood loss, and long-term trauma. Without modern diagnostics, doctors relied only on visible wounds and outward symptoms. Injuries that today would be considered survivable were frequently fatal in the 19th century. When trauma went beyond surface damage, such as internal bleeding, organ injury, or infection, survival was considered nearly impossible. Enslaved children were particularly vulnerable to extreme physical trauma. Forced labor, harsh punishments, unsafe working conditions, and neglect exposed them to injuries that would overwhelm even a healthy adult body. Broken bones were often left untreated or poorly set, leading to permanent damage or fatal infection. Deep cuts and wounds were common, and without proper cleaning or stitching, they frequently turned septic. The idea that a child could endure repeated trauma and survive contradicted medical expectations of the time. One of the greatest dangers following physical trauma was blood loss. In 1862, there were no blood transfusions, no IV fluids, and no understanding of shock as a medical condition. Severe bleeding often led to rapid weakness, organ failure, and death. Even moderate blood loss could be fatal for malnourished individuals, especially children. From a scientific perspective of the era, survival after extensive blood loss was not expected. Internal injuries were even more deadly. Damage to organs such as the lungs, liver, or intestines was nearly impossible to diagnose accurately. Without surgical intervention, or with surgery performed using unsterilized tools, patients faced overwhelming odds. Internal bleeding often went unnoticed until the patient collapsed. Children who suffered such trauma rarely lived long enough to recover, making any survival deeply puzzling to contemporary physicians. Pain management was another critical issue. Anesthesia was unreliable, dangerous, and rarely used on enslaved individuals. Severe pain placed immense stress on the body, increasing heart strain and weakening immune response. Trauma combined with constant pain could push the body into fatal exhaustion. The belief that black individuals felt less pain led to further neglect, compounding physical damage and reducing chances of survival even further. According to 1862 medical understanding, a child enduring repeated or severe physical trauma, while malnourished, untreated, and forced to continue labor, should not have survived. When such survival did occur, it defied the known limits of medicine at the time. Physicians lacked both the knowledge and the tools to explain how a weakened body could recover from injuries that routinely killed others. This is why such cases were viewed not as medical successes, but as scientific mysteries. In 1862, medical science simply did not possess the tools or knowledge required to explain extraordinary survival cases. Physicians relied on observation, outdated theories, and personal experience rather than evidence-based medicine. Without modern biology, pathology, or an understanding of how the body heals at a cellular level, many recoveries appeared mysterious or impossible. When a patient survived beyond expected limits, doctors often had no scientific framework to explain why. One major limitation was the absence of germ theory. Doctors did not understand how infections spread, why wounds became septic, or how the immune system functioned. Recovery from infected injuries, severe illness, or trauma was viewed as random or divine rather than biological. If someone survived an infection that typically killed others, medicine could not explain the mechanism behind that survival. This lack of understanding made unusual recoveries deeply unsettling to physicians of the era. Medical documentation in 1862 was also inconsistent and incomplete. Records were often brief, subjective, and influenced by personal bias. There were no standardized methods for recording symptoms, progression, or recovery. When a case did not fit known outcomes, it was sometimes dismissed, poorly recorded, or labeled an anomaly. As a result, survival that contradicted medical expectations often remained unexplained rather than investigated. Another limitation was the lack of diagnostic technology. There were no X-rays, blood tests, microscopes for clinical use, or imaging tools. Doctors could not see internal injuries, infections, or healing processes. Survival from internal trauma or disease was therefore difficult to understand because the damage itself was never fully observed. Without knowing what had healed, medicine could not explain how it happened. Cultural and racial bias further restricted scientific inquiry. Enslaved individuals were rarely studied with the same seriousness as white patients. When an enslaved child survived against expectations, the event was often ignored or attributed to superstition rather than medical curiosity. Racist beliefs distorted scientific thinking, preventing physicians from asking critical questions that might have advanced understanding. Because of these combined limitations, lack of theory, poor documentation, missing technology, and bias, certain survival cases stood outside medical explanation. To doctors in 1862 Mississippi, such events did not represent breakthroughs but mysteries. Science could not explain how a body endured what it should not have survived, leaving these cases suspended between fact and disbelief, unresolved by the knowledge of the time. In 1862 Mississippi, eyewitness accounts were one of the primary ways events were documented, especially outside formal medical institutions. Much of what is known about unusual survival cases comes from written observations by plantation owners, overseers, physicians, missionaries, and local officials. These accounts were often recorded in journals, letters, medical notes, or estate records. While not always precise, they remain critical historical evidence because they reflect what observers believed they were seeing in real time. Medical records during this period were inconsistent and highly subjective. Physicians often documented cases using personal language rather than standardized medical terminology. When a patient survived against expectations, doctors sometimes noted their surprise, confusion, or disbelief. These reactions themselves are significant, as they show that the outcome did not align with known medical patterns of the time. Even when details were limited, the repeated acknowledgement of unexpected survival gives these records historical weight. Eyewitness testimony from non-medical observers also played a role. Plantation overseers, family members, and other enslaved individuals often described physical conditions, visible injuries, and changes in health. While these accounts lacked scientific analysis, they provided context about the severity of injuries and the length of recovery. When multiple observers reported similar details, historians view such records as stronger indicators that something unusual occurred. However, these records were shaped by bias. Enslaved individuals were rarely given a voice in official documentation, and their experiences were filtered through those who controlled the narrative. This means that many details, such as pain levels, long-term suffering, or internal damage, were likely minimized or omitted. Even so, the fact that survival was recorded at all suggests it was noteworthy enough to challenge expectations, even within a biased system. Surviving documents also reflect the limitations of contemporary understanding. Observers often used vague or symbolic language, describing recoveries as unexplainable, remarkable, or against nature. These phrases indicate moments where witnesses lacked the knowledge to explain what they saw. Rather than investigating further, many simply recorded the outcome and moved on, leaving future generations with unanswered questions. Taken together, eyewitness accounts and historical records form a fragmented but powerful picture. They do not provide full scientific explanations, but they confirm that extraordinary survival did occur and was recognized as unusual by contemporaries. These records bridge the gap between documented fact and medical mystery, preserving evidence of events that science in 1862 Mississippi could observe, but not understand. Despite eyewitness accounts, medical notes, and historical references, the central question surrounding such survival cases in 1862 Mississippi remains unanswered. How did it happen? At the time, medicine lacked the scientific language and biological understanding needed to explain extreme resilience. When a body endured trauma or illness beyond expected limits, physicians had no framework to analyze recovery in terms of immunity, cellular repair, or physiological adaptation. Survival was recorded, but explanation was absent. Contemporary doctors often resorted to vague conclusions when confronted with outcomes they could not rationalize. Some attributed survival to luck, divine will, or natural strength without understanding the underlying processes. Others simply labeled such cases as anomalies and moved on. There was no culture of long-term investigation, especially when the subject was enslaved and considered socially insignificant. As a result, the question of why remained untouched. Modern medicine might offer possible explanations: genetic resilience, unusual immune response, or misdiagnosis, but none can be confirmed with certainty due to missing data. No blood samples, imaging, or detailed examinations exist to reconstruct what truly happened inside the body. The absence of reliable records means that even today, science can only speculate rather than conclude. The mystery survives because the evidence is incomplete. Another layer of uncertainty comes from systemic neglect. Because enslaved individuals were rarely studied thoroughly, their bodies were not understood with the same curiosity applied to others. If survival occurred, it was not seen as a scientific opportunity, but as an inconvenience to be ignored. This lack of inquiry ensured that critical questions were never asked, let alone answered. The unanswered question also reflects the broader limitations of 19th century medicine. Science had not yet up with biology, and observation alone could not unlock complex truths about human survival. Without tools to measure, test, or compare, extraordinary outcomes remained isolated events rather than data points. Medicine could witness survival, but it could not explain it. Ultimately, the mystery endures because it exists at the intersection of lost evidence, limited science, and historical injustice. What remains is not a clear explanation, but a lingering uncertainty that challenges both past and present understanding. The question is no longer just how survival occurred, but how many similar stories were never recorded, never questioned, and never understood.